Good morning to all, and I want to thank you for attending this MS Views and News program. My name is Stuart Schlossman. I'm president and founder of MS Views and News. Today's program is a Compass MS Care program. We are sponsored today by Bristol-Myers Squibb, Genentech, Sandoz, and TG Therapeutics, and I want to thank all of them, and I hope you all thank them as well. A little round of applause would be great. Let me get started with Dr. Cabot's intro. I mean, this is the person that's standing in front of you right now. And she wrote a perfect introduction for me, but she used the word I in front of everything. And now I have to say she or Dr. Cabot. Okay, so Dr. Cabot graduated from the University of New England Osteopathic Medical School. She completed residency in neurology at UMass, which I guess is the University of Massachusetts. She did a neurology immunology fellowship at UMass for the last 2 decades. And she's had the great pleasure of treating people with MS, starting initially in Maine and now in New Hampshire in a comprehensive MS care model. She works with a wonderful team, she says. Dr. Cabot works to offer loads of wellness programs so patients can also stay involved and active and enjoy life to the fullest. She does have the best patients in the world, she feels, so she feels blessed to work in this field. So let's let Dr. Cabot speak with you. She's going to be speaking again for about 55 minutes. She's going to speak about emerging therapies, including biosimilars and generics. She's going to speak about shared decision-making. She's going to tell you what that means, a little bit on symptom management, and let's let her take it away. And I will be back for the Q&A after her presentation. Thank you.
So thanks for coming today. I really loved learning about this whole program, especially for rural patients. You know, some of us are very close and live in the city, but being, you know, I do see quite a few people who live far from the office. So having programs like this is so exciting. A lot of our wellness programs, as you know, are also on Zoom and all that. So I'm extremely impressed with this whole program. And I'm really honored to be here. And I love that there's many things we're going to talk about today. So hopefully it's going to feel a little bit like I'm jumping around, but hopefully that'll keep it a little more exciting than just me droning on about, you know, medications and things like that. So I think you can't talk about MS and MS medications without talking about sort of our history, right? So our first FDA-approved therapy was beta-seron for relapsing forms of MS, and that was in 1993. And some of you in this room will probably remember that there was a lottery, and I won't ask for a raise of hands because that seems unfair. But this was a subcutaneous injection every other day. And today, with all of the successes that we've had, we have gone from 0 to, honestly, there's over 30 therapies, and it spans a very large range of mechanisms of action. Okay, so what that means is the way the drugs work, okay? So we still have a huge pipeline of investigational therapies, and we still have a long way to go to get to the finish line. So 20 plus years ago, when I did my fellowship in MS, my mentor said, you know, there's definitely going to be a cure for MS. And I feel with Paul, like, there's going to be a cure, there's going to be a cure. And I just think of all the changes and how rapid that seems. That's why I put the race car in here, how rapid it feels to have these changes. When you're the person who has MS and you're waiting for these therapies to come out, it feels like a snail's pace, right? When you're the person who treats the person with MS, you feel like, oh, I want better things. I want to fix this, right? I want to help. And research seems terribly slow, but there's a lot of reasons for that. There's a lot of clinical trials and a lot of safety studies. And, remember, MS is not like something that happens very quickly. So the studies have to take a number of years before, if you're counting relapses and you're counting all that stuff. So then things have to get safety monitoring, there's FDA approval, and then all those steps have to be done. It's really all for safety. It's amazing how many options we have right now. And the one thing is that there's not one perfect therapy for everybody, because if there's one truth to MS, MS is different for everybody. And I think Paul pointed that out so well. A lot of symptoms for MS are invisible, and that makes it really tricky when you're treating MS or when you're experiencing MS and you're trying to understand your MS. And that's why I think so much of MS, it's not just picking the right drug. It's also treating the symptoms, the mental health, the exercise, the wellness. All of it matters. Everything matters. Like, don't think we're just talking about one thing here. Everything matters, okay? So when we talk about medicines, and I thought this is the part of the talk I'm going to go through first, what I like to do is try to I put them into buckets, okay? So what we do is we talk about different mechanisms of action when we're talking about medication. So it makes it a little more manageable to understand when you're talking about mechanism of action or how the drug works, right? So if I talk to my patients about, and I list off a whole bunch of drugs, I talk about these drugs all day long. But if you're a newly diagnosed patient with MS and we start throwing these words around, it can be incredibly overwhelming. So we try to put it into little bite-sized pieces and then start the educational process. So these are some of the therapies that we have available right now. Okay, so we have interferon, so that's a class of medications. So we have beta-seron, Avonex, Rebif, and Plegridy. These are all in the class of interferons. They have differences between them. The differences between them can be sometimes how they're given, like the frequency and if it's intramuscular versus subcutaneous, how deep the injection is given. But they're all in the same class of interferons. Very similar risk and benefit profile too, and I think that's an important concept that we talk about a lot, is that there's no such thing as a medication without risk. So you have to make sure that even though these drugs have all been approved to treat MS, and when we talk about treating MS, we talk about relapses, we talk about MRIs, we talk about disability, they're all a little different, but they all have different risk too. You may have no side effects, you may get all the side effects. And the studies, those clinical trials are done on many, many patients so that you can get an idea of what the population experiences. So when I'm trying to teach someone about it, I can say, well, this medication has been tested in so many patients, and this is what those patients experienced. Okay, you don't want to be overwhelmed by those. You might want to look at like what % of patients had burping as a side effect. It may be a very low percentage of patients, but they're still going to list it there for you. Okay. So another category of drugs is we have Copaxone or glatiramer acetate. That is an injectable therapy that's also been around for decades. We have natalizumab or Tysabri. Tysabri has been around for a long time. This is an infusion therapy that's given once a month, highly effective. It is also, a natalizumab is the first drug we have that is a new biosimilar agent. So it's our first I'm going to get to that later because we haven't even talked about biosimilars yet. But Tyruko is the medication that was recently approved but not available yet. It's a biosimilar agent. It's natalizumab, SZDR, so I'll get to that. Again, risks and benefits to everything. And I'm not going to do a deep dive into any one medication because you can find all this information online. On different websites. You can discuss this with your own neurologist or whatever, but if there's something you want to talk about later, I'm happy to stick around. Sphingosine modulators are a really interesting class of medications. So they, first one was Gilenya. This was a first oral medication. We were all really pumped about this because a lot of our patients were, just giving themselves injections. And now there are 4. So because there are 4 different sphingosine modulators, we have Gilenya, we have Mayzent, we have Zeposia and Ponvory. They're all a little different. Okay, they all have little differences between them that may be important to your doctor or to you. So it really comes down to finessing your education on, how you feel about these medications and the risks and benefits and what the advantages of one drug may be to another. So Gilenya was our first one. And what these drugs do is they modulate the sphingosine receptors, which are part of the immune system, and get the lymphocytes to sort of sequester into the lymph nodes. And some of the newer drugs affect different receptors, less receptors, so they're more specific, okay? Then we have the fumarates. So we have multiple different fumarates. We had Tecfidera as our first one, dimethylfumarate, Vumerity, Bafiratam, and now generics of these are available as well. We have another oral drug called Mavenclad, that's cladribine, and that's a very different medication in the way it's administered, and it's different from all the other drugs. So each green box here is a different mechanism of action. We have teriflunomide or Aubagio, and then we have B-cell therapies. Now B-cell therapies, there's Ocrevus, which was our first FDA-approved one, which is ocrelizumab. Kesimpta, which is ofatumumab, and now we have Briumvi. So this is the newest one. And so there are little differences between all of these therapies. So if you have questions about them, feel free to ask your doctor. You can look at the Ultimate Treatment Guide on the MSAA website, which is excellent. Zoom in on that. And hopefully that'll give you a little more detail. Again, my goal was just to give you like an overview of all the options that are available today. So the goal of all our therapies, so what do our therapies do? So, when all the drugs that are FDA approved had to go through clinical trial, and they looked at basically 3 measures. Because why do you want to be on treatment, right? That's the ultimate question. So the thing that we look at are relapse rates, MRI activity, which is very kind of easy to look at. It's a very objective measure. You look at the number of T2 spots, you look at the gadolinium enhancing lesions, and you look at brain atrophy or T1 loss. And I hope you look at your MRIs with your doctor. I think it's fun to look at your MRIs. I think it helps in a lot of ways to look at your MRIs. And the other things studies look at are disability progression over time. And like Paul said, he has not really had a lot of disability progression over time. Everybody's different, so it can be a little frustrating for patients sometimes because they're like, I've had a lot of progression, some people don't. Some people have a lot of relapses. And so it's important to make sure that you report all of that to your doctor. So there's rigorous trials that the medications have to go through to get FDA approved, which I think is really important. I threw this slide up just because I think it's a very optimistic slide. So this is just clinicaltrials.gov. So I just Googled it like the day I made the slide, which clearly was July 5th. I think I had COVID that week, so I was like, I'm gonna get some work done. But look at that. I mean, the number's a little hard to see there, but it's in the thousands, okay? We have thousands of trials going on for multiple sclerosis, relapsing MS, secondary progressive MS, primary progressive MS, and even MS symptoms. So the acknowledgement that we are now looking at these other things like MS symptoms is pretty exciting because I feel like half of my time is spent, well, maybe more in the office, is spent managing not just the treatment of the MS and the diagnosing of the MS and going through the MRIs and all that. A lot of it's spent on how you're managing your symptoms, how's your mental health, how's your bladder, how's your spasticity, all that stuff. That stuff's really important. Cognitive issues like Paul was mentioning, fatigue issues, right? All those things. So I think that that's a really optimistic slide because you know there's a lot of work going on. So feel pumped up. You can always go on that website, clinicaltrials.gov, type in MS, type in symptoms, type in secondary progressive, type in primary, whatever you want, and you're going to learn a little bit more. So there's some new stuff, and so this is what I thought I'd bring to the table just for something new to look at that's being studied and researched. So you may begin to hear these words, so you can be like, I've already heard of that. Cabot told me, okay? So smoldering lesions is something that's being investigated and researched a little further. So something that has come up and that people are talking about is progression independent of relapse or disease activity. So even though you don't have a big relapse or you lose your vision or you lose your strength in your leg, you're like, I don't feel as good as I did 2 years ago, right? Like that kind of progression. So the truth is we don't really know how to treat that, right? So a lot of times we focus on wellness and symptoms, but you get the MRI and I'm like, yay, your MRI is stable. And the patient's like, yeah, but I don't feel good. And I know that's a real phenomena. Like when patients are like I'm happy my MRI is stable, but I'm also frustrated that my MRI is stable because I know I don't feel as good, right? So that comes down to trying to manage the symptoms and all that. But we're also the researchers, and I'm a treating neurologist, not a research neurologist. So the research neurologists are really looking into this, and I think you'll see more about this when you do your own reading on MS. One thing that they're talking a lot about are different types of cells in the central nervous system, because remember, MS is a central nervous system disease, so optic nerves, brain, and spinal cord. You probably all heard me say that. And these are called microglia. So microglia are in the central nervous system. They may contribute to both healing and damage. They can change their morphology, their shape, and they can migrate to sites of the central nervous system that have infection. So they're there to help protect you. So we'll talk a little bit about those. We'll look at these MRI features of PIRA. and paramagnetic rim lesions. I find that hard to say, which may be a sign of this chronic smoldering inflammation. So this is sort of up and coming stuff. So I asked a friend of mine who does research to give me this slide. I always get really excited when my nerdy friends send me slides to share with you guys, because I'm like, yay, fun stuff. And you probably haven't seen it. I hope this is new to you, because I don't want you to come and hear the same old stuff, you know. So this Dr. Chris Hemmond, who's just lovely, he's at UMass, which is a wonderful center, by the way, and we're really lucky to have all these wonderful centers near us. He's doing a lot of research on imaging, and so are a lot of other people looking at these paramagnetic rim lesions. So you see that little circle that's highlighted in the bubble. It's like a dark circle, and what they think that is iron, which can be, causing this progression, this smoldering progression. Okay. I'm going to pull all these slides up. Hold on. There we go. So what we think these chronic active lesions have in them is iron-containing pro-inflammatory macrophages and microglia, which are right at the edge or the outside of the MS lesion. All right, so that's what this slide is showing you. Thank you, Dr. Hemmond, for providing those slides. And the interesting thing is that you can see these paramagnetic rim lesions also on a 1.5 Tesla MRI. So this is something that they're researching, because a lot of times you will hear, dink. A lot of times there's some debate, do I have to have a 3 Tesla MRI? It's so much more expensive, blah, blah, blah. No, I think a really high quality 1.5 Tesla MRI with good software will be able to help us determine which patients, in the future, when we get better guidelines, who has this, who's experiencing this. And so it's a really exciting time for us. All right, so what are microglia? So are these cells you guys have heard of in the past? I know we talk a lot about B cells and T cells. Good. I wanted to share something a little different. There are many, many cells involved in the development of multiple sclerosis, and we're still trying to figure out what causes MS. That's a whole nother talk. It's inflammation in the brain, optic nerves and spinal cord. It's primarily an immune-mediated disease. These microglia, we've known about them for a long time. They constantly surveil, so their job is to continuously monitor your central nervous system, and they're looking for, they do all kinds of things, so there's lots of different types. So they clean up detritus. I love that word. I want my kids to clean up the detritus in their room. I'm like, pick that stuff up. They never do. I love them. They're great, but they're messy. So they pick up the detritus. You want the dead stuff gone, right? So their job is to clean up. They go to sites of infection. They phagocytize, which means they gobble up stuff. And they present antigen to T cells. So they're messengers, okay, to T cells and B cells, okay? So there are many different phenotypes. What that means is there's lots of different type of microglia. Like if you look up microglia, you're gonna be like, oh, look at all the shapes and all the sizes and what they do and all their jobs. So they're fascinating. And they carry out unique jobs in the central nervous system. So it really is, it's all about balance. And I put these 2 different pictures in here because it's not a simple balance, right? It's not just the one ball, big ball, little ball. There are many things going on in your immune system that are checks and balances that are responsible for sort of tipping the scales and perhaps causing inflammation or better healing, right? Because we want things to heal better. So our immune system is just completely full of checks and balances. We need cells that are going to help protect us and from infections, and that's what inflammation is supposed to do. But too much inflammation can cause demyelination and bad stuff, so there's all this crazy stuff going on at the same time. So this is a class of medications. You may have heard about this, BTK inhibitors. They are not approved for MS. This is all in research. But if you do look at online or you look at things online, you will likely hear some information, and I thought it would be fun to just look at these a little bit. Because you may hear more in the future. So these are oral drugs, so they're pills, and what they do is BTK works on B cell signaling, so again, messengers, right? There's a lot of messaging in the central nervous system. So these are intracellular messenger signals that work to help balance your immune system. I think the interesting thing about BTK is they work on both the innate and the adaptive immune system. They can also cross the blood-brain barrier. So therefore, they may have some different impacts on, inflammation, including leptomeningeal inflammation and inflammatory signaling. The hope is that there will be this may fill a gap in some of what is going on with our treatments now. We don't know, so keep your eyes on this. There are many different BTK inhibitors currently in research and under investigation. So let me just pull that up. So I'm not going to say these. So no, evobrutinib, tolebrutinib. So there's many. And I think unlike our other slide that had all the available disease-modifying therapies for MS right now, I think the difference here is that because microglia all have so many different jobs and they're also very different, they wear a lot of different hats, I don't think that we're going to be able to put these drugs all in the same box and say they all do this or they all do that. I think we're going to have to learn more about these. So these are not yet approved, and while new options seem promising, I think we never hang our hat on something until all the safety data is in and all the efficacy data is in. But looking at a new mechanism of action instead of rehashing the same old mechanism of action, like something new, might be exciting for us. And I think the hole that we want to fill is secondary progressive and primary progressive MS as well, or these patients who have progression independent of relapse activity. And we also have to throw aging in there, don't forget. Trials are on hold due to some patients experiencing elevated liver enzymes, so we'll have to keep our eyes on that. All right, so that was my short blitz through what's available right now and a little peek at what's coming with BTK. And again, we still have a lot to learn. But I wanted to at least go to biosimilars and generics. So you guys have seen generics out there on the market. And biosimilars are, for MS, we just got our very first one, as I mentioned. So biosimilar is a biological project that's similar to a biologic FDA-approved drug, and they have no clinically meaningful difference in terms of their safety, efficacy, purity, and potency, okay? So the biological agents, these are very, like if you look at a biological agent versus like a chemical agent, these are very large, complex molecules that are grown in live cells. They're hard to manufacture, and so it's important for them to prove that there's no meaningful difference. There are 40 biosimilars, over 40, available in the market in general. So if you may be on, a friend may be on a biosimilar for some other disease process, the only one that's a biosimilar that just got FDA approved that's not yet available is for Tyruko, which is natalizumab SZTN. All right, so how is a biosimilar different from a generic? So a biosimilar agent is made from living sources. They're a specialized process to manufacture. They're similar but not identical, and the hope is they'll be less expensive than the original biological agent. Generics are made from chemicals. They're typical simple processes to copy in most cases. They're a copy of a brand name, so once a patent wears out, they can go ahead and copy it. And they are less expensive than brand name drugs. So you guys have probably seen those comparisons. You can see like on Cost Plus RX or some of those other places where they actually are very transparent about pricing, that these drugs can be much less expensive. All right, so that was all I was going to say about generics and biosimilars. All right, and we're shifting gears again. But I really am passionate about this topic. And I hope that you are too, because I think this is, when you have so many options for treatment and so many options for symptom management and a lot of different options for wellness, it's really a lot about how you feel about what you're doing for your, to treat this MS and how we can help you achieve your goals, right? So I really do love that my patients get involved and they take the time to get educated and they don't want to feel rushed making a decision about their treatment, okay? I want you to be a partner in crime with me, okay? MS is an incredibly complex disease. I have patients who've had MS 30, 40 years and they're like, man, I'm still learning stuff every day. I'm like, dude, I am still learning stuff every day about MS. I love that. I mean, that's what we love about this. We're learning something new every day. I learn from my patients every day. It's an exciting time to, be able to work with people who are making progress. You have many, many, many choices when it comes to your MS. So because of that, I mean, you want to be involved in that process. But the educational part is really hard. Just like I don't understand my husband's a teacher, teaches chemistry, do we all remember that? If you don't do something every day or your job's really different, the language of MS can be very different. Learning about all these drugs, learning about the symptoms, learning about your emotional response, and treating all that and other things in your life. It's not just like Paul was saying, he was going through a divorce, right? A lot of other stressors in your life. That impacts us, right? So it's a lot going on in your life, and you want to take your whole life into context when you're trying to make decisions about your MS. So what is shared decision making? So that's us working together. Okay, so the doctor and the patient work together. So I don't know about you guys, but I know that it's really hard to communicate with the medical world, right? It's not always easy to get information that you feel is pertinent to you. So we have a lot of other ways to communicate and a lot of other really good resources. So in our office, we have a patient portal, where patients can email in. You can call a nurse, you can speak to the PA, you can speak to me. We also give out a whole 4 pages of here's some resources, some really good resources that might help you. And we may circle a few and we want you to dive in and look at this or look at that. But really, maybe not all of it is pertinent to you. So you may be like, I just want you to look at this one and this one, or this one and this one. But you need to have the tools to help become educated, and you want to get your resource from good resources. You got to use good resources to get educated. We want to use evidence-based medicine to help. What is evidence-based medicine? Science, right? Like typical science. So physicians are trained to use evidence-based medicine to help decide which drugs are most appropriate for MS, right? Just like they had to go through all those clinical trials. There's multiple papers. There's all kinds of literature on MS. We use the studies to help guide us. And then we take your story and what you're experiencing to help guide us. And then we put the two together to make decisions about your care, right? So these two sides need to come together to help make decisions, to help you have the best experience that you can. And there's a lot of reasons why shared decision can be helpful. Shared decision making, why in MS? So I think one of the things that's really hard is there are patient preferences come into play. And we know that if patients help make the decision about what they want to do, or they share what they like, they will probably stick with it. So if my 17-year-old son goes to the doctor and the doctor says, okay, you need to take your vitamin every day, and he does this, he's not doing it. Make that decision, So, but if you came in and you said, I'm really tired, like if my son had come in and said, I'm really tired, and the doctor said, well, we did a B12 level, your B12 level is really low, and if we treat the B12 level, maybe your energy will get better. I get it now. The 17-year-old gets it. He can understand that. And he goes, well, where do I get B12? Well, it's in that vitamin. If you take the vitamin, your energy might get better, okay? So we're all like that. So you can pretty much use any symptom model like that. And so the hope is, instead of me just saying, you should do this. Now remember, medicine is broken in many ways, and we're all really busy, and you're really busy, and da-da-da. There's a lot of constraints in everybody's time. But take your time to write down your symptoms, so that you get answers to your questions. Use the resource pages that we give you to help get answers to your questions. But it's an incredibly powerful thing when the patient is engaged in their therapy and wants to do better, right? I have a lot of patients who are really positive and really engaged in getting better, and it makes a huge difference. So if I say, if someone comes in and they say, well, I'm really tired, and I say exercise, sometimes I feel like patients want to kick me, and I totally understand that. I literally understand that. It seems cruel to tell someone who's tired to exercise, okay? Then I have to say, studies show, da-da-da-da. Exercise does this, exercise does that. What is it about exercise that's getting in your way? All right, so then we talk about well, what kind of exercise could you do when you're exhausted? That kind of thing. And then if you tried the exercise already and it didn't work, well, let's modify it. Let's find something better for you. And then maybe there are medications, things like that. So I think that this is really important time to put, what are you willing to do to get your symptoms better, right? So I think that's really good. Oh, and the other thing I do want to mention is that it's not just about medication choices. Like, I think we focus so much on shared decision making just in drug choices or what med you're going to go. Of course, that's really important, but it also is in all the other symptoms that we treat, right? And I know a lot of you guys end up treating your own symptoms with like exercise or rest or eating right and things like that, but it is part of everything we do with MS. So I really love that. How do you map out shared decision making? So there's lots of websites that talk about shared decision making. So you can use symptom trackers. There's symptom trackers on the MSAA website. Use the trusted resources from your neurology team. Write down your questions, hopes, concerns you have before your appointments. You can bring them in. And then if you have some idea, we're not going to think it's weird. You should tell us. And then if it's weird, we'll tell you. No, I'm kidding. But if we don't think it's appropriate for you, we'll tell you, right? Because the crazy thing about MS is it's different for everybody. We're all at different stages. Some of my patients are 18. Some of my patients are 80. They've gone through that whole life, right? So that's a lot of different things that happen in those years. So I think it's really important to throw your circumstances in there too. All right, I thought this was a really cool graphic, and that's the only reason why I put it. No, just kidding. So then we come together, right? So we come together. It may take some extra time. So you may come to the appointment and be like, I want to pick a therapy or whatever, you get diagnosed. The current recommendation is that if someone gets diagnosed, we do not put them on a treatment that day. The current recommendation is that we give you all the information, we show you the resources, we hopefully zoom in on one or two, and then we have you back to pick a treatment. Now, again, some of my patients are really rural, so it may be a phone call that we end up picking the therapy or a video call, or maybe the patient comes back in a week, but take your time. It may take extra time. It's definitely more work. When you talk to other, like my friends in Europe that treat, they see, they get 5 minutes with their patients. It's crazy. They can't address symptoms. Like it's the patients are really doing a lot on their own, but definitely write your questions down. You are not being the doctor. You should not feel that you have to make the decision. Sometimes my patients come in and I think they're like, well, you're the doctor, you pick. I don't actually get that very often anymore. I think, 10 years ago, 15 years ago, we would hear that more often. But I think patients are more empowered today. And I think that's great. I think it makes a better outcome for all of you. It's okay to pivot. I think Paul's presentation was such a good example of this. Pivoting regarding symptom management, pivoting regarding treatment options. If you don't like something, it's okay to pivot and move away or change your mind or move on. But you need to communicate, because once you leave, we don't know if you're having, you have to let us know if you're having symptoms or side effects, or it didn't work, or you didn't actually want to do it in the first place. Because sometimes patients I'll say, what's your goal? And they'll say, well, I want to lose weight. So I'll say, do you want me to set you up with a nutritionist? Yes. I set them up with a nutritionist or a sleep study or something like that. And they never go. And I ask them why, and they're like, oh, to be honest, I didn't really want to. And I'm like, oh, well, you should just tell me. Like, don't worry, it's okay. We'll find something else. But as you grow and you learn, you find there are so many options out there that'll help you make decisions and hopefully help you feel better. So confidence, education, confidence, and adherence. People who make their own decisions tend to stick with their treatments better. We know this to be true. It helps you be more confident patient. The problem why we don't always do it is time constraints. Patients don't have the tools to help them make the decisions, or they're unaware of the tools, or lack of relationship or communication with your doctor or team. Don't forget, it's a whole team. Okay, what happened there? Shifting gears. Ooh, I could have used one of your slides there, Paul. All right, so this is just a picture. This is a 57-year-old with a 30-year history of MS. And there are a couple of things I wanted to point out on the slide. I don't know if this will actually work. Oh, it does. So these, you guys look at your own MRIs, right? I hope. So these are MS spots here. So this is a 30-year history of MS. So someone who's had 30 years of MS, remember, Beta-Seron came out in 1993, okay? And we've had so many options since then. There's some brain atrophy, and there's some cord lesions, okay? So this patient may have lots of symptoms. They may have none. I mean, this is the craziness of MS. Like, it's very different for everybody. But a lot of my patients with a heavy burden of disease in the brain and the spinal cord will have a very, very different set of circumstances than someone has very few spots, okay? So that is what makes this a very interesting, I always tell patients, people are like, how was your day? I'm like, no 2 days are alike. I'm trying. So what kind of symptoms are patients dealing with, right? So you look at an MRI like that and you say, well, what kind of patients does this person could be having? Like, that's a generic slide, but maybe they're having cognitive issues, right? Maybe they're having some spasticity because of that spinal cord lesion. Maybe they have some weakness. Maybe they have low vision, fatigue. Anybody here have fatigue? That's an easy one. Maybe depression. Maybe some urinary symptoms or bladder bowel symptoms, gait trouble, lack of sensation, could be in the hands and feet. And there could be all kinds of other stressors. And I think this comes up in my office a lot, financial stressors due to a change of work or things that may be going on there, emotional stressors because of the MS, and caregiver stressors. Don't forget the care partner in this. The partner is also dealing with MS, right? So you can see a person who's had newly diagnosed MS today with very few symptoms could be very different from someone who's had MS for 30 years. It's different for everybody. I've had people who have come in and I've diagnosed them at age 70 with their second relapse. Their first relapse was when they were 20. They never had anything in between. Don't know. So it's just a continuously evolving field. So when you think of who's available to help you with those symptoms, if you have some or all or none of those symptoms, if we have a patient who has all of those symptoms, we use a multidisciplinary approach, right? So it means I'm going to be referring you to other providers who are way better than me at treating, let's say, bladder symptoms, right? So a urologist is an extremely helpful person on our team. So if we get the urologist on our team, right? It's awesome to have a mental health person. So mental health is not easy to come by these days, as you guys all know. But because of COVID, there was this huge need, and now there's a lot of different platforms for mental health, for counseling and things like that. There's online. Some people prefer in person. And there's lots of other different ways. But mental health people are really beneficial. Neuropsychologists take about a year to get into. Our favorite, PT, OT, and speech. Sometimes we need to get the visiting nurses to come help the patients with social work. Actually, the MS Society does have nurse navigators, which are also really helpful. Physiatrists, so they're mobility experts. A neuro-ophthalmologist, my favorite, just retired. I cry every day. Radiologist, I'm often on the phone with the radiologist going, what do you think? What do you think? What do you think? So, we discuss cases in the office with the other neurologists. And then an orthotist, that's someone who helps with bracing and mobility. Additional resources I've put on the side here. But there are a ton of resources. Actually, I think the program that these guys have put together is phenomenal. So if you go online and look at their resources, it's actually excellent. All right, so this is a really important slide. You don't want to blame everything on your MS, and you don't want to let other doctors do it either. It's very convenient if you go in with a complaint for someone to say, oh, it's probably your MS. I'm like, what? So I have some good examples. I had a patient who ruptured her appendix, and she walked around for 3 days saying, man, my MS hug is really bad. I'm like, what? So I'm like, no. So there are lots of studies like that. So don't blame everything on your MS. Something doesn't seem right or it seems different. Look for the other things, so you'll see, sometimes we check your B12 or we'll say, you got to see your primary care. And I know I get the eyeball roll when I tell patients to see their primary care, but you don't want to blame everything on your MS because you don't want to miss something else that's treatable. Because you have MS for a lot of years, I wish it protected you from everything else. Like you're like, hey, I can't get hypertension because I already have MS. I should be all done. I got my thing. I'm done. But it doesn't work that way. So we need to take care of the whole person, and that's your primary care person is part of that team. So sometimes, you need to investigate different ways. Sometimes you see a rheumatologist or, whatever. But we need to put it all together. It needs to make sense, right? Now, I used to have a really cool slide, and I really couldn't find it, so I apologize. This slide is not as good as my old slide. But all symptoms matter, okay? So even little symptoms. This is true for everybody. It doesn't have to be MS, but you need to remember that all your symptoms are interconnected, that you're one person, and if you're having symptoms in one part of your body, it's impacting everything you do. So we want to make sure to do the best we can to treat the symptoms. I'm going to pick on the bladder, but let's think about the bladder for a second. So if someone has the urinary frequency, urgency, or incontinence, and this started, right, and they're like, oh, I'm not going to go out with my friends tonight because I don't want to have an accident. I don't want to have to stop. I'll be so embarrassed if something happens. So then they don't go out with their friends, right? That's not good because maybe they don't go to the gym anymore. Maybe they don't work out anymore. Maybe they're home. So now they're home and they're getting deconditioned, and now they're depressed. Because they're home and not working out and they're depressed, their spasticity is worse because they're not exercising. All of this, is a vicious cycle, all because of one symptom, the bladder, right? So all symptoms matter, and we got to try our best to manage those symptoms. It doesn't mean we can get rid of them entirely, but be picky. Like if something is bothering you and it's not getting better, be picky. Like try the bladder physical therapy. I know, again, I get the eyeball roll sometimes. When I say, hey, I need to sign up for PT or urology or whatever, and I know you guys get doctored out, it's very understandable, but I think this is really where the wellness and the feeling better begins, is making sure that you're trying to take care of all those symptoms that are bothering you. So there are symptom trackers. I think there's more than one now. Journaling is great. I love the journals because you can also throw in something you're grateful for, and then you can put something like, okay, my spasticity is really bothering me, and I want to talk about that at my next appointment, What are you doing that's working, and what is not working? These are perfect things to put in your journal to bring to your appointment. Your journal could be an index card. It could be the back of a receipt. I don't care. Just bring something in so that you've been thinking about it. So, because every time you come in, I want to work on something to make it better. Like if there's something that's bothering you, let's make a plan to make it better, okay? You want to prioritize your symptom, like which one's bothering me the most? What are we going to work on today? Because remember, we don't want to change too many things at once. I'd rather work on one thing and then, or especially if it's a medicine, never start two medicines on the same day. Give them a little time in between. You don't want to get overwhelmed by these. Sometimes I find that I can be overwhelming. I walk out of an appointment, I'm like, oh my gosh, I just told that person to do like 30 things. So if I overwhelm you, please email me back and be like, can we take a step back here and do one of these things? And that's totally fair. And at every appointment, make sure that you feel that you're getting something out of it. Have a goal. It doesn't matter if it's a tiny goal or a big goal. Like maybe you just want to learn more about wellness, or maybe that's great. When we're in this place where we're just learning about wellness, that is awesome. So I wanted to talk about sleep issues in MS. There are a lot of studies on sleep in MS. Oh, I don't know how I'm doing on time here. Okay. So more than 70% of patients with MS will say they have sleep issues. All right. See, this is a problem because a lot of my patients raised their hands and said they're tired, right? So 40% will report insomnia. Insomnia is very common in the general population, I might add. Okay, so what a great opportunity to treat, right? Like this is something we can focus on. So a lot of my patients I'll be like, how's your sleep? What is it? What can we do about it? What time do you go to bed? What are you drinking before you go to bed? What are you eating before you go to bed? All that kind of stuff matters. Do you have limb movements of sleep? Do you have to get up to pee a bunch? And a lot of these people have watches now, Garmin's or smartwatches that can track your sleep, which is really helpful as well. I have a lot of high-tech patients, way better than me. So it's important to try to nail this down. We can help your sleep. Hopefully we can help your fatigue in MS, right? So that's a place where we might work with a sleep specialist. Sleep apnea is also very common in MS, so that needs to be treated separately by a sleep specialist. I'm a huge fan of non-pharmacologic methods, and I know that a lot of people think Americans just want to pop a pill to feel better, but I have to say, not in my experience. I feel like a lot of my patients take the pills they have to take somewhat begrudgingly. They're like, I get it, like I need to take this in order to do that. But most of my patients would prefer not to be on a whole lot of pills, like, to be honest, like, and that's the truth. So we know, again, eyeball roll time, exercise can improve fatigue 40 to 50%. That's across the board, many studies. But it needs to be adjusted individually, right? Not one shoe fits, right? I used to, love jogging. Well, not love it. Okay, no, I don't love it. But I loved how quick it was. I could get a little 20-minute run in and feel really good. I got old. I got knees and hip pain. I had to pivot, all right? I had to switch to something else. So MS does the same thing, right? And then aging, you age with your MS. But maybe your exercise will be breathing and yoga and upper body. Awesome. Like anything you do is awesome, okay? But you got to do it, right? You got to be held accountable. You got to acknowledge the fatigue as a problem, and you got to use it as a tool, the exercise as a tool. And I think the pivoting part is important here, because someone might say, well, I do this and it works for me. And you're like, I tried that and it didn't work. What's wrong with me? There's nothing wrong with you. You just have to have something else. And don't get mad at yourself if you have an elliptical machine and a bike machine and a whatever else machine sitting in your house and you hang your clothes on it. That's okay. Move on. Find something else. Sell that stuff on Craigslist. Get something else that works for you, okay? The best place to start, in my experience, is with a really good PT and OT program. There's some great programs here in Manchester. We're really lucky. Excellent programs. And then you springboard from that. I mean, PT can be kind of pricey sometimes, so you want to get the most out of it, right? So you want to take as much as you can. They also have a support group at the PT program here in Manchester, which is great. And that's free, right? So go to that. But make sure that the exercise is safe for you. Like I had a patient in the other day, she wanted to swim, but she didn't know how to swim. So we're trying to figure out ways to get her exercise in without drowning her. So that's important. And we want to make sure that you're gaining, right? Like, okay, so I just had summer. I didn't do as much over the summer. You get back in the winter now, and you're like, okay, no more barbecues, less ice cream. I've got to get back into my routine, right? So everybody comes in telling me this. And remember, if you get sick or knocked down, it may feel hard to get back on that exercise again, right? It's like, oh, it set you back. Don't give up. Just keep going. It's like little Dory. Just keep going, or Nemo, whoever said that. And acknowledge heat intolerance. Today is a perfect example. It's not actually that hot out, but man, is it humid. And it's a real thing. So cold cloths on the back of the neck. Ice water is excellent. So get a Hydro Flask, one of those big metal flasks, put ice in it, put water in it, just keep hydrating. Now you're like, I just told you, lady, I have to pee all the time. I'm like, okay, then we're going to work with our team, right? We're going to work with our team to try to figure out one thing at a time. But we want to work with you to strengthen. There are a lot of studies looking at this, and hopefully we can do non-pharmacologic approaches. There are medication options for fatigue. There were studies done that showed that these were not effective. They were small studies. So there are patients who we've used non-FDA approved treatments all the time. And this is something that you would discuss with your doctor. Amantadine is actually approved for its dopamine medication. It's approved for influenza and Parkinson's, generally very well tolerated. It's a small dose. Small studies, modest benefits. I feel like I could say that to all the medicines for MS fatigue, right? Small studies, modest to no benefit. That being said, I have patients who say, sometimes, this certainly helps me immensely, right? So whether it's modafinil, that's Provigil, or armodafinil, or amantadine, or methylphenidate, or whatever, I think we do not throw pills at you. That's the point. You need to try the exercise first. You need to continue to do the exercise. We need to rule out the sleep apnea. So modafinil, for instance, is approved for shift work sleep disorder, obstructive sleep apnea, those kind of things. And some of my patients say it doesn't help at all. And some say, I think it does help. We also want to make sure that we're not placebo affecting you, right? We don't want you to take a medicine that isn't working, okay? Ampera, or 4-aminopyridine, dalfampridine, is for gait disorder with MS, and some of my patients do feel that that helps their fatigue as well. And different antidepressants have also been studied and shown to help with MS fatigue. So sometimes you might get a medication that you're like, why is she giving me a flu medicine for fatigue, or why is she giving me an antidepressant for fatigue? That's because these small studies, and we don't have one medicine to treat MS fatigue. There is not one FDA-approved medicine to treat MS fatigue. It's all trial and error, lots of pivoting, okay? Lots and lots of pivoting. These are little small slides, I apologize. But I'm telling you everything, so hopefully the people online can see them too. So as far as fatigue, because it is the number one thing that people complain about, it is multiple things will pump into your fatigue, right? So you get many things that can cause fatigue in MS. We want to make sure that we're not missing something else. Again, this is where that little, you have to be, a little Sherlock Holmesy here. If someone comes in and says, well, I have MS, of course I have fatigue. Well, how do I know you don't have B12 deficiency or a thyroid problem or you're not sleeping? We've got to look at those other things, okay? If we don't look at those other things, we're not doing a good job. If you are deconditioned, if you are not exercising, you are likely to be fatigued. Depression and anxiety, it's like they're hard to pull apart from fatigue, right? A lot of patients who are depressed are fatigued. So it's often the case where we may need to use the neuropsychologist to help us peel those two things apart. And if we can treat depression, maybe the fatigue will get better. If we treat the fatigue, maybe the depression will get better, right? You can see how all these things are connected, okay? And then other causes of fatigue. Oh, don't forget, things I do cause fatigue, okay? I may be giving you some medicine for your spasticity, like baclofen or gabapentin for pain, and you're like, I was actually feeling pretty good, and then she put me on that medicine, and now I'm tired. Don't forget to keep track of that stuff. Maybe we can back down on some of those meds. Maybe we can try a little more exercise, stretching, treat the spasticity that way, and less meds and less fatigue. See, but it's got to be personalized for you, and that's the point, okay? It's got to be something that you want to think about and let us know. Aerobic activity, mindfulness has been shown to help, good sleep programs, PT, OT, wellness, lots of resources. All right, so I did want to bring up mobility, thank you, mobility issues. So a lot of what we do is managing spasticity. Again, a lot of our spasticity medicines cause fatigue, so it's like a little seesaw, teeter-totter, right, where we're trying to figure out what's the best dose without making you zonked. So we always try to start with PT and OT. Make sure we're not missing low back pain, degenerative disc disease, things like that. And there's some new things that are recently approved, including the Psionic Neural Sleeve. Have you guys heard of that? Anybody? No? There we go. We got some fans in the back. Maybe they can talk to you guys later. But these are exciting electric stimulating devices that help. Basically, this is how I explain it. When you have MS and you have a speed bump like in your spine with a little scar after the inflammatory plaque is healed, what happens is that signal sometimes has a hard time getting to your leg. There's nothing wrong with your leg, it's just not getting the signal. So if you have weakness, sometimes electronic stimulation can help with the strengthening of that musculature. So these are all things that you can, I think they're on your website, the MS News and Views website as well. So it's really good. This is, when you talk about your passion, I think that was what I love too. I love Paul's whole mission statement there. But when you think about what else can we do to help treat the whole patient, we started at the beginning of this program talking about drugs and experimental therapies and shared decision making and symptom management. But wellness and connecting with other people who have, and I'm preaching to the choir because you're here, but spread the word. We have a bunch of wellness programs that are associated with our MS Center. They're all free. They're all supported by a grant from the hospital. The only one that's in person is the painting class because the teacher's right there helping you. And I know that we have a lot of talented artists because I am blown away by what people can do. I can't draw a stick person, but that's our teacher in the middle, Beverly, and these are just an example of some of the things that people drew from pictures in one class. So every day after our painting class, I'm like, show me the pictures, show me the pictures. So it's just so exciting, and I think it's a lot of fun. So painting is one expression of passion, right? I always joke about stress and anxiety are, talk about a medical condition that causes stress and anxiety. Hey, you have a chronic neuroinflammatory disease, and I can't promise what's going to happen. I don't know when it's going to come back. I think this has gotten a little better with some of our newer therapies. I think that, we have different therapies now that we have more data about relapse rates that are more optimistic and things like that. But it is a common comorbidity with MS to have a lot of stress and anxiety. And so we have a class called mindfulness. Has anyone done mindfulness? Oh, phew, good. Excellent. It's a free class. It's an established class since the 70s. Like, this is a program that is on Zoom so we can reach our rural patients. So it doesn't matter where you live. You do not have to come to the office. But mindfulness is extremely helpful for cognitive issues. It's great for fatigue. And it's something that you can do from home. These classes are, if you did them in the community, could be $400 or $500. Again, all covered. But this is worth your time if you have cognitive issues, let's say. Anybody in the room with cognitive issues? Right? Fantastic for cognitive issues. So if someone comes into my office and they say they have cognitive issues, I'm going to say, listen, let's do this first and see how it goes. It's free. You do it on Zoom. You don't even have to spend any gas money or motorcycle gas money. You can let me know what you think after the 8-week course. There's a before test and an after test to see how you do. We know it increases cortical gray matter thickness, which I didn't really believe until I really, really read the studies. But it's really amazing opportunity for you, so please take advantage. When we talk about rural patients, we have a lot here in New Hampshire, Vermont, Maine. What are some of the barriers? Why don't patients participate? Why don't patients participate in exercise programs? Why don't they participate in wellness programs? Maybe they don't take their medicine. Like, what are the reasons? So mobility and transportation come up as number one. Fatigue comes up a lot. I am too tired to take that class at night. Totally understandable. We have 2 classes, one during the day, one at night. Come up with excuses. We'll try to fix it. Lack of perceived benefit. Some people just think that it's not going to help. We may not, but it's worth trying. Cost. So we try to get rid of the cost. And then technology. I have patients with no computers or no Wi-Fi, okay? So this is something that we work on with the MS Society, MSAA, MS is BS, all these wonderful groups that help financially with patients who don't have these types of products. Because to be honest, almost everything's online. When I realize this when I hand out my education sheet and circle things, I'm like, ooh, literally almost everything is online. So if you're a person who lives, rurally or does not have easy access to the internet, or you don't have a computer, this is not good. So we have to fix that problem first. So briefly, just looking at MBSR, it increases that, you can tell I like this, it increases that gray matter thickness. Patient reports on this have been outstanding. Patients really, for the most part, like it a lot. There are different parts of the brain, so areas just behind the frontal lobe. So you think about cognitive flexibility. Like, a lot of my patients are like, sometimes it's hard for me to be flexible thinking. Impulse control, impulse behavior. It also works on the hippocampus, our tiny hippocampus. But these are important structures in the brain. If we can help your limbic system, maybe it'll help your mood, right? So these are the very deep structures of your brain. Think of like primitive self. Like, I always think of our old brain and how that all developed over time. But the nice thing about it is that it's covered program. Thank you. So I have no idea how I'm doing on time. I'm just rolling along. But in summary, we have so many options. I did love that when Stuart asked me to do this program, he said, speak about this, this, and this, because it was kind of fun to jump around for me, and I hope it was for you too. But we do have a lot of options for therapy, and we're blessed. Like, having done this for 2 decades and having the honor and the privilege to work with MS patients for 2 decades, it's been amazing to see. We have all kinds of resources for you through, and I think the website, MS News and Views, is amazing. It has lots of different resources on there for you. Use the good resources, okay? good decisions with your doctor. And then symptom management is complicated, and it is different for everybody. But the great thing about these programs is hopefully you can talk to someone at your table and share something about what you tried, and maybe it'll work for somebody else. So that's how I learn every day. That's how our office learns every day, and we try to bring that to our patients every day too. So I think that's the end of my formal slide presentation. Stuart, back. Sorry, I keep looking that way.
Excellent. I am back, and I want to let you know that your talk was fabulous. I mean, really, really fabulous.
He says that to everybody.
So thank you very much. And hey, everybody, let's say thank you for Dr. Cabot's talk. Going forward, one of the questions asked online first is how to choose an affordable FDA-approved infusion.
Oh, that's a great question. So the question, I don't know if you guys could hear it, was how do you choose an affordable FDA-approved infusion? So basically when it comes down to choosing your medication, you're going to have a conversation with your doctor, you're going to have probably some blood tests to see what's a safe option for you, and then you're going to make your decision based on that. And then your insurance is going to come into play, so your doctor will write the order, and then we fight with your insurance. We do a lot of that behind the scenes. There's a lot of work that goes on behind the scenes to try and get the medications approved, the one that you want. The companies will often have copay assistance programs. It gets tricky depending on the insurance, and to be honest, I have a great team, and I lean pretty heavily on them when it comes to this. But all the companies also have, that make the infusion medicines, also have people at their company that work for you, the patient, to help you get access. And I think sometimes we underutilize that. So you can, as a patient, reach out and be like, hey, my doctor prescribed this medicine. I have a copay, it's X dollars. Do you cover it? Now, normally you get signed up for these programs right away in the office. So you're like plugged in right away. But you have to remember every year you have to sign up for them again. So it's not complicated. I guess it is. It's complicated. I wish we had I wish it was easier, but it's hard to battle MS and then battle insurance as well. I couldn't agree more. And I spend a lot of time writing letters and fighting for patients to get what they want and need. So we write a lot of letters. So ultimately it may be some back and forth with the insurance company or some back and forth trying to get, does it matter if you get it at an outside infusion center versus in a hospital setting, what's more affordable? But you should let your doctor's team know, like, hey, this doesn't seem right. I have a huge copay or something like that. And then you work with those three-way party kind of to be like, how can I make it work for me? Sometimes you might have to pivot in a class. So if you're on one medication, the insurance may say you have to try the generic first. Okay. Your doctor may be like, that's okay. There are no available, generics for infusion therapies right now. Tyruko's coming out, but we don't have it yet. It's a biosimilar, not a generic. And I don't know how that will impact patients because it's not out yet. And a lot of my patients do get $0 copay assist, which has been really helpful. I think one other thing that people should know about is Mark Cuban's Pharmacy Cost Plus RX, which is something that you can go online and look at. It's very transparent cost. There are no infusion therapies on there, though. So, great question, but complicated.
Yep. And another complicated one is that, so if you have private healthcare insurance and you need prescription assistance from a pharmaceutical, you can get it. But if you're on a government insurance, such as Medicare or Medicaid, you cannot get it. What do you tell your patients about this?
Right. So we work with grants. So sometimes the companies, even though you may have those types of insurance programs, you can work on with grants. And some of the generics that I talked about are shockingly less expensive on the online pharmaceutical Cost Plus RX website. So some of my patients were just getting their medication through that.
Right. But then there are those generics that if a person is not able to get because their medication is not available through Cuban's website, that being on Medicare, it could actually cost them a lot more than a person that is on private healthcare insurance. What options do they have?
Right. So one thing I think that patients forget is that they are the consumer for the insurance company. They're the person that has the right to talk to the insurance company and ask, what's available. And so when you're shopping for your insurance and you know that this may be your drug, you want to make sure to keep that in mind when you're picking your insurance. And then you have the right to talk to your insurance company and say, I have this is what my doctor prescribed, why aren't you covering it? And then we can write letters saying, this is the appropriate therapy. That's as far as, I can't control our out of control healthcare system, which is unfortunate. But if I could, I'd wave my magic wand and all drugs would be free. Legal drugs. So I really would. It is an enormous stressor for a lot of patients, and I think that some of my patients have absolutely no problems at all, and other patients, we spend hours writing letters or back and forth with insurance. So each case, again, is going to be different based on your insurance, but do not forget, you're the consumer. You should also be writing letters saying, this is the medication I want, talking to we can do 3-way conversations with your insurance company, the medication, us, and you, because you need to get your nose in there and be like, why aren't you covering it? Or how much is my responsibility? Sometimes patients can get money through MSSBS, and I think MSSBS is more of a New England thing, but that can help defray the cost. We ask them to use the MS. If you're not active politically with the MS Society, you should be. You get an email, you write letters arguing for cost-effective medications. I do this all the time. You should write to your senators. I know this gets a little above what the question was, but it does make a difference. Every time a patient writes a letter, shows up at the State House, it makes a difference. When the people who make the decisions hear from a human who is dealing with the actual problem, it makes a difference. So I know that's like on a grand scale, but it does make a huge difference. And sometimes it's as simple as signing a letter, so that the MS Society sends you. Do you guys get those letters or appeals? So it's very easy to do. You just go to the MS Society and you sign up to be an advocate. And you can... Activist. Thank you. But it really makes a difference, so I would say do it, because, look what's happening now. There's already 10 drugs that are going to, come down, not MS-wise, but, what Biden's doing now to make it more affordable. If we could get that for MS drugs, boy, would that be awesome. So that's what we need. So change at the top.
Thank you. I have to ask the in-person audience, is there anybody out there that has a question? Raise your hand, please, because either Paul or Bill will go around with a microphone. I cannot see you, so I don't know where you are. Doctor, is there anybody waiting to ask a question?
No, they're just smiling all really nicely. Does anybody want to share what they've done for wellness or symptom management or something that they think in the community that's been really helpful, either online or something like that?
We have a question here.
Oh.
About the smoldering.
Oh, yeah. So this smoldering or progression independent of relapse activity is something that is under research. So I wanted to bring it up because there's a lot being written about it right now, and you might read about it. And maybe some of the new medications that are in research, the BTKIs, might, this may be a method to treat that. But it's a super exciting area for us. But again, it's one of those things that it's super exciting in research. It's not quite actionable yet, but this is the hope, right? So they found something, the hope is, right? And that's what we keep doing with MS and how we keep finessing the treatment of MS. And that's an awesome question. That's why I kind of put that in there, because I thought it would be tantalizing and new and fun to look at. And, and Chris Hammond is right at UMass. So, we are really lucky because in our cell, we have all these wonderful people who are just so close and doing really neat research. So sometimes my patients will actually take advantage of that. I'll say, you can call up the research center down at UMass or wherever and see if you're a candidate if you want to look at something. It's pretty cool.
Great, thank you. Any other questions from the audience?
Yes, we have another.
Can you guys hear me okay? Thank you, Dr. Cabot. She's my doctor personally, and she's the best. Thank you for doing this talk. As a former healthcare professional working with doctors, it's very hard to find a doctor who's caring and listens and wants to help you and not just write a prescription for a pill and send you on their way, because she genuinely cares. And I just wanted to add in that I am actually a psionic user, which she had a slide about. It's the leg brace that people are wearing, similar to the Bioness. but it's got 24 electrodes on it that stimulate your muscles, 4 major muscle groups, your quads, your hamstrings, your calf, and your shin. And I am a physical therapist that I had to stop working with a year ago. But I was an orthopedic physical therapist, and now I'm currently seeing a neurologic physical therapist. And they're two different worlds, but the gist of it is I understand the therapy world, and it's interesting as a patient, but also as a therapist, to use this machine because it is just groundbreaking, eye-opening. I was at a point a couple months ago where I couldn't stand at the kitchen sink and just washed even a couple dishes. And after 3 weeks of using this device, I was able to stand and do things around the house and run errands. I'm a mom of 3 children and a husband who works from home, so to say I'm busy is an understatement, and to have my life come to a complete halt over the past year and a half with declining physical activity, and knowing as a physical therapist how hard that is, was really just eye-opening for me and shocking. I've learned what it means to be humble now. I've always known what the word means, but I always loved helping people. I was the helper, and now I need help, and I needed to ask for help. So that was an eye-opening experience. But going back to the neural sleeve, the psionic, it has shown such a huge improvement. I couldn't walk more than 2,500 steps, and I'm back. I'm sorry? Oh, the question, the question was, the psionic sleeve is helping. Is there anything more with the psionic sleeve that you would suggest?
Sure. So that's a great question. I'm excited about new technologies that sort of jump the circuit. And I hope that these are now FDA approved in New Hampshire. I think we were one of the last states. And so it's something that is not covered by insurance, which I think is tricky. But it's something that people could look into online. And it may be something that patients could really benefit from. So I have a number of patients who tried it, and but most of them have done the work on their own. It comes with an app, and you Zoom with them, so it's pretty neat. It is work. I think that's important. It's not like you're going to put it on and be like, yay! You have to work at it, and the muscles were tired, right? So they have to strengthen. And I think that's the key: is do not give up on it. Again, it's work. Symptom management is a little bit of work, but when you start seeing the benefits, and it helps you do more, and then your mood gets better and your energy gets better, it's all worth it.
Thank you for that. By the way, the psionic sleeve is not available in all states of the United States.
Still,
they are
not
working
yet.
on that. We interviewed the CEO of Psionic Sleeve a few weeks ago, and that can be found on our YouTube channel. If you want to know more about it, you can go to the YouTube channel, look up Psionic Sleeve, and get the full details of everything about that device. All right, next, anybody else in attendance with a question? Question? No
I think we're
questions?
good. Yeah.
I got questions online for you, all right?
Okie dokie.
So the next one we have online is, what is your opinion about stopping a DMT when you're 60 plus?
That's a great question. So to be honest, I think this is the biggest debate in neurology. So I try to go always to the conferences, and I love debating this with my friends, and I always go every month to our meeting. I do all the stuff. And every time I go to a meeting, I go, what age do you guys stop your DMT? I'll tell you, we don't know. The general rule of thumb is, if you look at the American Academy of Neurology and all the recommendations, if someone's been stable for 10 years and they're on a lower efficacy DMT and they're 60 plus, it's probably okay to come off. Did you hear the word probably? The risk of relapse goes down as we age. Aging has its own issues, right? We drop out neurons, we know this. There's degenerative things that happen as we age, right? Our balance gets a little worse, my vision is terrible, like all this stuff that happens as we age. But with MS, it could be more pronounced. Maybe some of those old symptoms get a little worse. So how much is the medicine helping is the question, because the drugs are all studied in people who are under 55, essentially, most of them. So the good news is that they are doing a lot of trials. So they just did one with 55 and older. Wasn't that helpful. I mean, it was okay. But they're doing one now with patients 60 and older. Oh, I just blanked on the name of it too. I'll think of it. And so they're enrolling patients, and I think we'll have some really good data soon. So I do think that it's a one-on-one discussion with your neurologist. Some people are very comfortable stopping their therapy. Some people are very uncomfortable stopping their therapy. I have a lot of patients who stop around 60 plus, 65. And then but I do think it's very important to, number one, have a low threshold to call if you have new symptoms. Boom, right away. Number two, keep getting the MRI to make sure we're not missing silent lesions, because silent lesions can happen in the brain and you don't know, but that's a sign that there's still activity, right? So then in that case, I would want to put the person back on their therapy. But I have patients who say, I'm just so much more comfortable staying on my medicine. You have to weigh the risks and benefits of that, right? Like some medicines are more immunosuppressive than others. So maybe we will say, okay, well, let's pick one that's less immunosuppressive. We'll go with that one when you get older. So again, it's a one-on-one discussion with your neurologist. And I think it's very much in practice. A lot of people do come off their therapies. As we age, we know the risk of relapse goes way down. So it's appropriate to do that. But again, some people are not comfortable doing that. So until we have a study that says you absolutely must, but I think because we're all biologically different, I just had a woman I diagnosed who was 62, just got diagnosed with MS. She probably has had it a little while, but still, if she's 62, what do you do, right? So everybody's different. This disease will keep me humble forever. And that is the best question out there right now. So science will help us. Studies will help us.
For that. Thank you for that. Next one. How about when you have other illnesses such as diabetes and the treatments cause your sugars to go up? Who's responsible?
It's all my fault, okay? So when someone has diabetes, which is a very common disease, there's type 1 diabetes, type 2 diabetes. We have to be aware of that when we're treating your MS, because if your MS is not under good control, maybe we need to give you steroids. Steroids are the one drug that can temporarily increase your blood sugars. But in my practice, I try not to use steroids if I can, because it means I haven't got good control of your MS, right? If you need steroids, it means you're having a relapse or new disease activity. Steroids are a Band-Aid, but steroids will up your blood. They're a great drug to help stop inflammation, but they will up your blood sugar. They will give you insomnia. They'll cause potentially aseptic necrosis of a joint. They increase your risk of cataracts. So I think if someone has diabetes, I try to pick a medication where we don't have to use steroids. So that's one thing. And then we talk about type 2 diabetes a lot because we want our patients to have optimal weight, increased exercise. I refer my patients to the weight loss clinic if they're having issues with that, and they should be working with an endocrinologist if their diabetes is not under good control. So it's a team approach, but if I have a patient who needs steroids and they have diabetes, you can bet your stars I'm going to talk to the primary care or whoever's managing the diabetes to be like, you need to tell me what to do, because I am not the one writing the insulin. I want to make sure the right person knows, right? So that the patient has power, like maybe the patient's the one who adjusts their own sugar, their own medication. But a lot of my patients have diabetes, and it's important to talk about. A lot of my patients have hypertension. These are common diseases: hypertension, diabetes, osteoarthritis, low back pain is really common. So we want to make sure that we're getting you. I refer a ton of patients to get those things treated. Exercise helps all of them. Just saying. You can roll your eyeballs again.
Thank you. Thank you. Next question I have online. This is a little bit more complicated. If a person wants to donate brain tissue, don't they have to be dead first?
Yes. Yes. So some people get brain.
Can you tell us?
Some people get. Yeah. So that's a good question.
Where a person can go to get signed up for this?
To be honest, I haven't looked at that in a little while, so I'd have to look at the website. But there are places where you can donate once dead, not alive. And then some people do get brain biopsies for MS, especially if the MS looks what we call tumefactive. So sometimes patients will have brain biopsy. That's sometimes how we get brain tissue. But brain banks are, I know there's some out west. I don't know where the local ones are around here, but I have patients who told me I was signed up, but I'd have to go back and look. I apologize.
Great, thank you. There's probably a good chance that the research center that you spoke about earlier in Boston, they probably do it as well. I know that the University of Miami Research Center, Neurology, does it there as well. I'm sure that
Out west they do,
big,
yeah.
I'm sure that the big centers around the United States, the big research centers that are affiliated with hospitals, probably all have something going. But you could also just call the National MS Society and ask them about this too. Is there anybody in the audience with any questions? I can't see you, so I don't know.
No, we're monitoring. We're good.
Any questions
This
out
is
there?
smart. I have to tell you, this is a really smart crowd, buddy. That's all.
They must be.
They're very smart. Very
All right.
well armed and dangerous.
I appreciate that. So, we have no more questions online either. So if nobody has anything in person, then we're good for the day. And that means that you spoke about everything so well and they gave so much knowledge that nobody has any questions to ask.
Got it. Thank you.
There you go. So
Thank you very much.
with that, I'm going to just say, since nobody out there has any questions, I do want to thank you, Dr. Cabot. I can't wait to get back there again. Not that I was there now, but I can't wait for MS Views and News to get back there again. And hopefully maybe we'll bring it a little bit further north. Maybe we'll get up to Concord. Maybe we'll go a little bit further north than that, so we could draw people in from Maine if there's nobody there from Maine, and do other things as well and get people from the outside area to be more involved with the programs and do more things up there and learn more, okay? So again, I want to thank, for the last time today, I want to thank Bristol-Myers Squibb, Genentech, Sandoz, and TG Therapeutics for sponsoring today's program. And so I say thank you, and I hope you do all as well. And I'm going to call it quits for the day, and we're going to say adios, okay?